Hello, welcome to week 2 of Special Topics, the Integument and Wound Care. This week we are going to dive into talking about specific types of wounds. This first lecture will be on arterial wounds, venous wounds, and traumatic wounds. The objectives of this lecture are to 1. Describe medical diagnostic testing and interventions for arterial, venous, and traumatic wounds, and 2. Describe PT tests and measures and interventions for arterial, venous, and traumatic wounds. We will first discuss general interventions and material related to all 3 wounds. Then we will specifically talk about each wound type. For all wound types, lifestyle changes including nutrition and smoking, and managing medical risk factors including coronary artery disease, hypertension, diabetes, COPD, cholesterol levels, triglycerides, and other related factors are all important things to consider. And the general PT examination for all wound types should include assessment of pain, sensation, circulation, musculoskeletal and neuromuscular tests and measures as well. In addition, patient and family education is imperative to providing information for prevention, for living healthy, for healing wounds, specifically about nutrition, smoking cessation, and specific exercise. In general, PT interventions will also address impairments, address functional limitations, and address participation restrictions. Now we're going to talk about arterial insufficiency ulcers. The following 4 slides all depict examples of arterial insufficiency ulcers. Note characteristics between all pictures that characterize arterial insufficiency. Specific diagnostic testing related to arterial insufficiency is listed on this slide. We will talk specifically about each one of these in the following information slides. Plethysmography, arterial duplex scanning, arteriogram, TCOM, also known as transcutaneous oxygen monitoring, and a toe brachial index. Plethysmography is a fancy name for an ABI. It takes pressures along the arterial system at specific points in the arms and along the legs. It measures blood flow and extremities via pressures. Arterial duplex scanning uses ultrasound technology to look at the major arteries in the arms and the legs. It can tell specifically if there are blockages, how much the flow is, if there's increased pressure, if there's getting perfusion to a particular location or area. This is important in knowing if your wound or the area that you're trying to heal is getting adequate blood supply. This is an image of an arteriogram. It's an X-ray of an artery that's been injected with contrast medium, so it's radiographic. As you can see in the picture here, the right side of your screen has a lot more areas that are not very well lit, indicating there's not great blood flow there. TCOM, or transcutaneous oxygen monitoring, is a way to look at how much oxygen is actually getting to the tissue area related to the wound. So oxygen is diffused from the capillaries through the epidermis, but if you're not getting oxygen to the tissue and you don't have perfusion, you probably are not having good luck healing, or your potential for healing is fairly poor. Most of us are familiar with ankle brachial index, or ABI. ABIs look at the macrocirculation, so are you getting adequate blood supply through most of the major arteries in a limb, in the legs mostly. But it doesn't take into account the very small blood vessels that perfuse toes. So the toe brachial index, or TBI, looks at how well toes are perfused. It's the ratio between the toe pressure and the highest of the two brachial pressures. Now that we've reviewed some medical diagnostic testing, let's look at some medical interventions that may be used by other members of the team to work alongside the interventions that we're doing as a physical therapist. Pharmacological management, or medications related to wound healing, are important to look at and to know how they're affecting what you're doing. So pain medication, if the patient's on an anticoagulant, on antiplatelets, vasodilators, antihypertensives, or statins, it's all important to know how those are affecting your treatment and how it may be contraindicated for you to do something or not do something. When a patient has an arterial insufficiency wound, there are surgical options kind of along a continuum. Debridement may or may not be indicated depending on the appearance of the wound, if there's a lot of necrotic tissue, and dependent on the blood supply. Revascularization is possibly a surgery that could be performed to attempt to restore blood flow to the area. Common bypass surgeries are femoral to popliteal, femoral to tibial, or femoral to femoral. They also have the option of doing some percutaneous balloon angioplasty. So they go in with the balloon and they try to open up the arteries to restore the blood flow. Oftentimes they'll add a stent as well to make sure that the artery will stay open and will not constrict again. Endarterectomy, thrombectomy, and thromboendarterectomy are all terms that describe going in and removing parts of an artery, parts of the lining of an artery, or taking out a thrombus that might be blocking blood flow. And then finally, if attempts to restore blood flow, to continue to heal the wound, are not effective or not options for other medical reasons, a patient may end up with an amputation because of a wound in a limb. Here's a specific look at a femoral to popliteal bypass. So if you look at the figures, there's a blockage along the line of the femoral artery where it divides down into the popliteal artery below the knee. So the graft would just bypass. They suture in a vein above the blockage and reconnect it below the blockage, thus restoring blood flow. Here is an example of removing a blockage or a thrombus from an artery. They surgically open the artery, remove the blockage, and close the artery again. Here's a good visual of percutaneous balloon angioplasty with a stent. So you can see in the vessel on the left, that artery is very narrowed, very constricted at that particular point. So they've gone in, usually through a groin, depending on where it is, and they use instruments and a stent to then open up that area. The stent in the picture is completely open. When they insert it, it's like a little small cage, and then they open it up. That will keep the artery open and blood flowing. So we've just talked about some medical interventions. Let's talk about physical therapy tests and measures. An absolute necessary part of any exam related to arterial insufficiency or a wound on a leg or a limb, regardless of if you know the etiology yet or not, is to check pulses. You want to make sure that you know where to palpate the dorsalis pedis, posterior tibial, popliteal, and femoral pulses. If you don't know where to do that, you need to review your surface anatomy. A lot of times, especially if someone has edema in their lower legs or they're a larger person, it can be difficult to palpate those pulses. If you're not sure, you can't feel it, you need to get a Doppler ultrasound to be able to assure that they have decent blood flow and that they have pulses. This slide gives a guideline to interpreting ankle brachial index pressures. So it's the systolic pressure of the lower extremity over the systolic pressure of the upper extremity. Values can range from 1.3 or 1.4, clear down to very, very poor, as example, less than 0.45. Above 1 often is seen on a report as normal, but it actually is not normal. It really just means the vessel is not compressible, so you have lots of hardening of the arteries. If you have hardening of the arteries, there's a good chance that you also have narrowing of the arteries, especially in someone who has diabetes, and especially in the small vessels of toes. 1 to 1.1 is considered normal. Anything less than 0.8 is significant arterial disease and should be debridement by a physician only. Obviously then between 0.8 and 0.1 is kind of a gray area of mild arterial disease, where if it's cleared by a physician, they may allow physical therapists to do some debridement as well. And then less than anything 0.45, you're not going to have healing unless you have some kind of revascularization surgery to restore blood flow to that area. In addition to checking pulses, you can also check capillary refill by depressing the nail bed or the tip of the toe or finger in a patient. Anything more than 3 seconds is considered abnormal. You can also look at the ruber of dependency. If you elevate someone's leg and it becomes pale within 25 seconds, that indicates they have severe arterial insufficiency. And venous feeling time, anything greater than 20 seconds is arterial insufficiency as well. What about other PT interventions? As we've talked about, starting from week 1, we will be looking at the whole entire person, not just the hole or the wound in the person that we're working with. So what about gait training? A lot of times patients who have arterial insufficiency have intermittent claudication when they're walking. So giving them strategies for mobility that will decrease those symptoms, making sure that you're doing things to improve their functional capacity and improve their quality of life. Therapeutic exercise can send more blood to active muscles. It also increases the number of mitochondria and increases the release of nitric oxide, which is the vasodilator. So important when you have narrowed vessels, if you can dilate them as much as possible, then that will also reduce symptoms of intermittent claudication and will help their overall function. So what about education? You want to make sure that they know that they need to protect their feet and their lower legs. So making sure that they're wearing pants, that they're doing everything possible not to have any kind of a wound, because if they get one, it's going to probably be very difficult to heal. With that also goes making sure that they're inspecting their feet and their lower legs on a regular basis. We've seen that kind of combination of comorbidities, and a lot of times the cardiac ones of peripheral artery disease, coronary artery disease, also go with diabetes mellitus. A lot of times people have both. So just making sure that they have appropriate footwear for the time being if they have a wound, making sure they're relieving pressure off that they don't have any footwear rubbing up on a wound, and then making sure that they get some kind of permanent footwear that's going to prevent additional wounds. Positioning, you want to make sure that they are avoiding prolonged lower extremity elevation. So specifically, how are they going to sleep? Legs up while they're sleeping is probably going to eventually be painful. So talking with them about options for sleeping, lifestyle, other positioning that might help them would be a good thing. So now finally, after all of this, we're getting to actually taking care of the wound. Most of the time with arterial wounds, your intervention is going to be conservative. You want to still try to get rid of the necrotic tissue, but a lot of times these arterial wounds are very painful. So doing debridement is either 1, not safe because of blood flow, or 2, it's super painful. So making sure you're choosing dressings and topicals, which we'll get to, that will get rid of that necrotic tissue. If they have dry gangrene, which means it's black, it's hard, but it's not weeping, you want to leave it alone. It's kind of like a nature's Band-Aid. You don't want to give them an actual wound that they don't already have. Most of the time in an inpatient setting, you're not going to see these patients. They will be a surgery patient, there's not really any skilled physical therapy interventions to be doing for these patients. But if you're in an outpatient setting, this person might walk into your clinic for another reason, and then you see this. So just to be aware of it. If eschar is unstable, that means it's weeping, it's draining, it's painful, it has pus, it's discolored, the foot is discolored. It probably needs to come off. But before you do that, you want to make sure you know what their ABI is. You don't want to do sharp debridement without knowing what their blood flow is. It's always a good idea to talk to the other people on your team as well, most importantly the physician. You want to make sure that you're always protecting the peri-wound. Because this wound, arterial wounds, are happening because there's not blood flow and tissue is dying, it's at risk for extending these wounds pretty quickly and pretty severely. And then lastly will be dressings, which we will talk significantly about in a later lecture. You just want to make sure that you are following guidelines for selecting dressings in general for wounds as appropriate. So what's the take-home message for arterial insufficiency? The clinical wisdom is just because you have a pulse does not mean you have good circulation. We talked about a lot of other medical diagnostics to look at microcirculation versus just macrocirculation. The other take-home message is debridement is a great intervention. It can clean up wounds pretty quickly, but you always want to proceed with caution. You need to know the blood flow, you need to know tolerance, you need to know the goals of care, you need to know what the physician wants, you need to know what's appropriate for the patient. So it's not an always pick up the scalpel and the tweezers and the scissors kind of thing. Now we're going to talk about venous insufficiency ulcers. In the next 4 slides you will see wounds that are characteristic of venous insufficiency. Let's talk about medical diagnostic testing related to venous insufficiency. The first specific test is a venous duplex ultrasound. For this test, ultrasound technology is used to look specifically at veins, the valves, the structure, specifically to check and see if there's anything that's blocked. In a venogram, it's much like an arteriogram that we talked about earlier in the presentation, where dye is injected into the vein system and it's looked at using an X-ray. Again, it also looks to find blockages, collapsed veins, veins that are not functioning. People who have venous insufficiency are at increased risk of developing blood clots because their blood flow, their venous return, is not done in an effective and efficient way. Therefore, pharmacological management often includes anticoagulants such as Lovenox, antiplatelet medications such as aspirin or Plavix, and sometimes the medication known as Trental. This is a vasodilator and anti-inflammatory medication. It can improve the flow of blood through vessels by changing the viscosity of the blood. Surgical options for venous insufficiency wounds include debridement, skin grafting and skin substitutes, vein ligation, vein stripping, or a technique for advanced chronic venous insufficiency called subfascial endoscopic perforator surgery. This surgery addresses the incompetent perforating veins, which then decreases the venous reflux and improves blood flow. Specific PT tests and measures related to venous insufficiency are to always check for signs and symptoms of deep vein thromboses. Also looking at an ABI to assure that there's also adequate arterial supply. Oftentimes patients can have mixed disease where they have venous insufficiency as well as arterial disease. You also want to check the venous filling time. And as always, education is a significant component of PT intervention for venous insufficiency. Again, the same things that you talk to patients about for their arterial insufficiency, making sure that they're protecting their feet and lower legs to prevent any kind of wound, knowing that if they get one, they're going to have a more difficult time healing those wounds. Making sure they're inspecting their feet and their lower legs routinely for sores, wounds, calluses, anything that could lead to issues. Same thing for footwear, making sure that they have appropriate footwear if they have sores on their legs, sores on their feet, and making sure they have a permanent plan in place. And then also positioning. Because the hallmark of venous insufficiency wounds is poor venous return blood flow and pooling, related to swelling and edema in the legs, you always want to educate your patients on the importance of lower extremity elevation. Ulcer prevention is a crucial component to PT intervention in dealing with patients who have venous insufficiency and venous ulcers. Compression for life often comes as a huge shock to the patients that I see, that they're going to have to wear compression garments for the rest of their life. I always tell them that it's like getting dressed in the morning. You put on your socks and shoes, you're also going to put on your compression garments. There's good evidence out there that supports that if you do not wear compression, you will have a recurrence of venous ulcers. Local wound care. So addressing the wound that you see, you need to get rid of dead tissue. Venous ulcers are often very moist, lots of drainage, so you want to make sure that it's moist and not wet. You want to make sure you're absorbing drainage appropriately and protecting the skin around the ulcer so that it doesn't become macerated and turn into a wound. Compression is always a component of treatment with venous insufficiency ulcers. Most of the time you want to have a low stretch, multi-layer compression dressing over the top of your wound dressing. Examples of these include Uniboots, Pro4, multi-layer dressings, or sometimes people create their own with different materials. And then as always, dressings to appropriately take care of the wound. We will talk about dressings specifically in a later week. The most important take-home piece of treating a venous insufficiency ulcer and venous insufficiency is you have to reduce the edema. If you don't reduce the edema, you're not going to get that extra fluid back into circulatory system, therefore decreasing stress on tissue, decreasing drainage. You're just not going to heal that wound if you don't reduce the edema. The next two slides give a nice table that talks about characteristics and how to determine whether or not they're venous wounds or arterial wounds. They include looking at pain, position, presentation of the wound, peri-wound, pulses, and temperature. So with regards to pain, most of the time venous ulcers have mild to moderate pain, contrasted with arterial ulcers that are very, very painful. Where are the wounds located? Most venous ulcers are on the medial lower leg and the medial malleolus. The size of them, they can become circumferential. With arterial ulcers, most of the time they are on distal toes and the dorsal foot. What do they look like? Venous ulcers have irregular borders. Usually they're red, and they have lots and lots and lots of drainage. Arterial wounds, on the other hand, have really regular borders. They're usually circle. They're pale tissue, whether it's yellow, dry, black eschar. They usually don't have very much drainage. The peri-wound of a venous ulcer has lots of swelling, and it also has that hemosiderin staining, kind of a maroon to reddish to purplish color. That's the heme deposits that are in the tissue to stain that have leached out of venous blood. They look a little bit differently on different colored skin tones, but it's very obvious once you've seen hemosiderin staining that that's what it is. The peri-wound of arterial ulcers typically has thin and shiny skin. Oftentimes the limb does not have any hair, and it just is a pale or white tissue. With venous wounds, pulses are often normal. With arterial wounds, they are diminished or absent. And then also checking the temperature of the skin or the limb with venous insufficiency is a normal or a warm temperature, but with arterial insufficiency and arterial wounds, it's typically a much cooler. Now we are going to talk briefly about traumatic wounds. This is an example of a surgical wound that was created because of trauma to a leg. This is a fasciotomy that was created due to trauma to a leg causing compartment syndrome. For medical management of traumatic wounds, the primary concern is infection. Therefore, when you're treating these wounds, you want to first make sure you're debriding any necrotic tissue. You're maintaining a decreased bacterial load with the dressings that you're applying and with the cleansing treatments that you're giving. And you want to give local wound care as appropriate, so address the features of the wound that you see. Oftentimes, traumatic wounds are incredibly painful, and that might affect your treatment plan as well. Pharmacological management of traumatic wounds includes antibiotics, both systemic and topical, as well as pain medication. Also can potentially be systemic or topical. Surgical options may include debridement, incision and drainage. That might be possibly something that gets repeated several times. Secondary closure, so if you remember back to week 1 talking about closure of wounds, secondary closure is leaving it open for a while and then closing it after that. Some traumatic wounds may require skin grafting to get quick coverage depending on the location of the wound and to prevent further injury, loss of function, things like that. This concludes our lecture on arterial, venous, and traumatic wounds. For further information, please refer to your textbook, Wound Care Made Incredibly Easy, or check out the additional reference of Wound Management Principles and Practice.